Welcome. I'm Lieutenant David Good, and I will be presenting Anesthesia Management of Electrolyte Disorders. The topics for this presentation include a brief introduction to the physiology of water and electrolyte balance, followed by a discussion of the signs and symptoms, pathophysiology, treatment modalities, and anesthetic plans associated with disorders of sodium, potassium, calcium, and magnesium. The topics discussed in this presentation are the same as those listed on the RNA 894 Exam 1 topics list. I'll begin with the body's fluid compartments. Total body water is approximately 60% of total body weight and is composed of both intra and extracellular compartments. The intracellular compartment is the largest and is about 66% of total body water. The extracellular compartment is made up of both interstitial and intravascular fluid. The movement of water between the different compartments is governed by both oncotic and hydrostatic pressures. For example, intravascular fluid is pushed out of capillaries by the hydrostatic pressure produced by ventricular contraction. The movement of fluid out of the capillaries is opposed by the oncotic pressure exerted by intravascular electrolytes and proteins. This pressure pulls fluid out of the interstitial compartment back into the vasculature. Water hemostasis depends on normal electrolyte and protein concentrations, as well as functioning membranes with energy-intensive ion transporters. Without water and electrolyte hemostasis, neurons and myocytes are vulnerable to dysfunction. The body employs specialized sensors to monitor serum osmolality and water balance. As depicted in the upper left diagram, a decrease in intravascular water volume produces hypovolemia and a state of hypertonicity or increased osmolality. An increase in osmolality is sensed by osmoreceptors in the anterior section of the hypothalamus. Stimulation of these receptors leads to the sensation of thirst and the secretion of antidiuretic hormone from the posterior pituitary. ADH works at the distal convoluted tubules and collecting ducts of the kidney, increasing water absorption and intravascular volume. Baroreceptors located in the common carotid and aorta sense decreases in blood pressure related to hypovolemia and also stimulate thirst and the release of ADH. The lower left diagram shows the anatomy of the glomerulus within the nephron of the kidney. The specialized cells of the macula densa and the juxtaglomerular cells sense hypovolemia through a decrease in renal perfusion pressure. This decrease stimulates the release of the enzyme renin. As seen in the large diagram on the right, renin converts angiotensinogen to angiotensin 1. Angiotensin converting enzyme then converts angiotensin 1 to angiotensin 2. Angiotensin 2 stimulates a variety of responses. One is again seen in the upper left diagram, stimulating thirst and the release of ADH. The other is seen in the larger diagram, where it stimulates vasoconstriction and the release of aldosterone from the adrenal cortex. Aldosterone causes sodium reabsorption at the principal cells within the collecting ducts of the kidneys. Water follows the sodium via oncotic pressure and increases intravascular fluid volume. Serum osmolality is normally between 280 and 290 milliosmoles per kilogram. A level greater than 320 milliosmoles per kilogram is considered extreme and must be prevented. Osmolality can be calculated by shorthand at the bedside using the formula 2 times sodium plus glucose divided by 18 plus blood urea nitrogen divided by 2.8. The major ions of the body include sodium, potassium, calcium, and magnesium. The normal levels within the body can be seen on this slide. Note that sodium is the major extracellular cation, while potassium is the major intracellular cation. Their exchange via the sodium-potassium ATPase is essential for the normal function of cells. Because sodium is the single greatest contributor to the number of osmoles in serum, diagnosing and treating hypo or hypernatremia depends on the patient's osmolality and total body water. Both decreased and increased serum sodium levels can exist in a patient with hyper, hypo, or euvolemia. This can be seen in the above diagram. Several disorders can lead to hyponatremia, and the pathophysiology can vary based on the cause. Hyponatremia can be present with decreased total body water due to renal disease states such as diuretic excess, mineralocorticoid deficiency, salt-losing nephritis, renal tubular acidosis, metabolic alkalosis, ketonuria, and osmotic diuresis, or by extrarenal issues such as vomiting, diarrhea, third space losses, pancreatitis, and muscle trauma. Basically, for the patient to be both hyponatremic and hypovolemic, he or she must simultaneously lose water and sodium. Hyponatremia in the presence of normal total body water can be caused by a salt-restricted diet, glucocorticoid deficiency, hypothyroidism, high sympathetic drive, drugs, or syndrome of inappropriate antidiuretic hormone. Hypervolemic hyponatremia can come from renal losses such as acute or chronic renal failure, or it can manifest due to avid sodium reabsorption associated with nephrotic syndrome, cardiac failure, or cirrhosis. This chart from Stolting provides a quick reference of the signs and symptoms associated with hyponatremia. Anorexia, nausea, and general malaise typically occur early, whereas neurological signs, such as seizures and coma, occur late. Severe hyponatremia can cause brain herniation and death. The treatment for hyponatremia depends on the patient's current osmolality and fluid status. Hypovolemic hyponatremia is treated with normal saline to replace both fluid and sodium losses. The underlying cause should then be treated to prevent recurrence. With euvolemic or hypervolemic hyponatremia, water should be withheld and the patient should be started on a loop diuretic. It's important to pay close attention to both acute and chronic symptomatic hyponatremia. Acute symptomatic should be treated promptly with hypertonic saline and a loop diuretic. Chronic symptomatic should be treated slowly with normal saline to prevent central pontine myelinolysis. The anesthetic management begins at pre-op, and if possible, the procedure should be postponed until sodium levels can be normalized. If postponing is not an option, treatment should start at pre-op and continue through the procedure. Close monitoring of the patient's sodium level and fluid volume status are required. If needed, all hypertonic saline solutions should be given through a pump. Patients with hypovolemic hyponatremia are prone to dramatic decreases in blood pressure with the induction of anesthesia. Vasopressors and inotropes should be readily available to support the patient immediately after induction. Congestive heart failure is a common cause of hypervolemic hyponatremia. Invasive hemodynamic monitoring should be established prior to induction to determine cardiac function and to guide fluid therapy. Transurethral resection of the prostate, or TURP, can lead to hyponatremia due to the rapid absorption of fluid from open venous sinuses in the prostate gland. Although isotonic solutions used today are much safer than hypotonic, the risk of TURP syndrome still exists. Regional anesthesia is preferred for this procedure for continuous neurological assessment. General anesthesia can be performed with routine sodium monitoring. TURP syndrome is more likely to occur with procedures lasting greater than an hour and bladder pressures exceeding 15 centimeters of water. TURP syndrome presents as cardiovascular symptoms of fluid overload and neurological deficits. Hypernatremia is not as common as hyponatremia because the body is very well adapted to respond to hypertonic states via the vasopressin thirst mechanism. But when it does occur, it can be present during states of low, normal, or excessive total body water. Hypovolemic hypernatremia can be present with renal issues such as osmotic diuretics, loop diuretics, post-renal obstruction, intrinsic renal disease, and profound glycosuria. It can also occur due to extrarenal issues such as diarrhea, GI fistulae, burns, and sweating. Euvolemic hypernatremia can also be caused by renal and extrarenal issues. Renal issues include diabetes insipidus, while extrarenal issues include insensible losses from the skin and respiratory tract. Both hypo and euvolemic hypernatremia are caused by water losses, whereas hypervolemic hypernatremia is caused by sodium gains from hyperaldosteronism, Cushing's syndrome, hypertonic dialysis, intravenous sodium bicarbonate, sodium chloride tablets, hyperalimentation, hypertonic saline enemas, and saltwater drowning. Stolting provides a quick reference of the signs and symptoms associated with hypernatremia. The earliest signs and symptoms include restlessness, irritability, and lethargy. Muscular symptoms usually come later. Progressive hypernatremia causes significant neuronal shrinking as water exits the cell and enters the cerebral circulation. Increases in vascular volume can lead to intracranial hemorrhage. The treatment for hypernatremia depends on the patient's fluid status. Hypovolemic hypernatremia is first treated with normal saline to correct the fluid deficit. Then the hypertonic state is treated with hypotonic saline. In the hypervolemic patient, loop diuretics are employed. If the patient has renal failure, dialysis is utilized. Euvolemic patients typically have diabetes insipidus. It's determined whether or not the patient's DI is neurogenic or nephrogenic, and he or she is treated respectively. The anesthetic management begins at pre-op, and if possible, the procedure should be postponed until sodium levels can be normalized. If postponing is not an option, treatment should start at pre-op and continue through the procedure. Close monitoring of the patient's sodium level and fluid volume status is required. Patients with hypovolemic hypernatremia are prone to dramatic decreases in blood pressure with the induction of anesthesia. Fluids, vasopressors, and inotropes should be readily available to support the patient immediately after induction. Invasive hemodynamic monitoring may need to be established prior to induction to determine cardiac function and to guide fluid therapy. Potassium is the major intracellular cation, and as such, measuring serum potassium does not measure total body potassium. Rather, it's a measurement of factors that regulate potassium distribution through different water compartments. Normal total body potassium depends on muscle mass. Generally, young adults have the highest total potassium, while children and the elderly have lower total potassium. Potassium levels are primarily regulated by the distal nephron, where it is secreted in response to aldosterone. Excreted potassium increases urine volume and increases serum pH. 90% of dietary potassium is secreted by the kidney and most of the remainder by the digestive tract. In response to kidney failure, the digestive tract will secrete a greater percentage. Hypokalemia can be caused by decreases in net intake, losses, or transcellular shifts in potassium. Potassium losses include renal and gastrointestinal. Renal losses include hydrochlorothiazide, loop diuretic, mineral and glucocorticoid, and antibiotic administration, as well as magnesium depletion, surgical trauma, hyperglycemia, and hyperaldosteronism. Gastrointestinal losses include vomiting and diarrhea, Zollinger-Ellison syndrome, jejunal bypass, malabsorption, chemotherapy, and nasogastric suction. Transcellular potassium shifts can be caused by beta-adrenergic agonists, tocolytic drugs, insulin, alkalosis, familial periodic paralysis, hypercalcemia, or hypomagnesemia. The signs and symptoms of hypokalemia generally include cardiac and muscular problems such as dysrhythmias, muscle weakness, cramps, paralysis, and ileus. If the degree of hypokalemia is life-threatening and emergent, potassium can be administered intravenously at a rate of 20 MEQs over 30 to 45 minutes. The patient's ECG must be continuously monitored to assess for dysrhythmias caused by the potassium infusion. The enteral route is preferred for non-emergent hypokalemia cases. If IV administration is chosen in a non-emergency situation, the infusion rate shouldn't be faster than 20 millimoles per hour. Whether or not potassium should be administered immediately before surgery is controversial and depends on the institution's policies. If possible, hypokalemia should be treated days before surgery. However, potassium replacement immediately before surgery may be indicated for patients with dysrhythmias, CHF, or who are taking digoxin. Potassium levels should be monitored perioperatively. The most common ECG change associated with hypokalemia is the presence of U waves. ECG changes on day 1 and 4 of hypokalemia can be seen in the picture. To prevent further decreases in potassium, the anesthetist should avoid administering insulin, beta agonists, bicarb, and diuretics. It is also prudent to avoid hyperventilation and respiratory alkalosis. Hypokalemia can theoretically prolong the effects of muscle relaxants. The anesthetist should titrate doses based on nerve stimulation. Hyperkalemia can be caused by an increase in net potassium intake, as well as disturbances in normal potassium excretion and transcellular shifts. Decreased potassium excretion can be caused by acute oliguric renal failure, chronic renal disease, hypoaldosteronism, triamterene, spironolactone, NSAIDs, and drugs that inhibit RAS. Altered transcellular shifts can be caused by succinylcholine, acidosis, lysis of cells, and iatrogenic boluses of potassium. It's important to note the sudden increases in serum potassium levels may be due to hemolysis of the blood sample drawn. Rejaws should be performed if this is suspected. Most true hyperkalemias can be seen on the ECG. Causes for hyperkalemia during surgery include succinylcholine administration, rhabdomyolysis, and acidosis. The signs and symptoms of hyperkalemia can vary depending on whether or not the condition is chronic or acute. Patients with chronic hyperkalemia can withstand high concentrations of potassium with mild symptoms such as general malaise and gastrointestinal disturbances. Patients with acute hyperkalemia can experience weakness, paralysis, nausea and vomiting, bradycardia, and even asystole. Initial treatment of hyperkalemia is focused on driving potassium inside the cell. Techniques include administering calcium chloride, injecting 10 units of regular insulin with an AMP of D50, and administering bicarb while hyperventilating the patient. Long-term treatment of hyperkalemia focuses on removing potassium from the body. These techniques include fluid boluses of normal saline and administration of furosemide as well as ketoxylate enemas. If the patient has renal failure, dialysis may be required. The patient's potassium level should be below 5.5 milliequivalents per liter prior to the induction of anesthesia. The anesthetist should be aware that preoperative sedatives may decrease ventilation, causing respiratory acidosis, and may further exacerbate the hyperkalemia. As seen in the picture, hyperkalemia can cause the disappearance of P waves, prolong the QRS, and produce peaked T waves. Succinylcholine should be avoided because it increases serum potassium levels 0.5 milliequivalents per liter per dose. Lactated ringers and normal sol should be avoided because they contain 4 milliequivalents per liter and 5 milliequivalents per liter of potassium, respectively. Hyperkalemia can exaggerate the effects of muscle relaxants, and doses should be changed accordingly. The anesthetist should avoid hypoventilation and acidosis throughout the procedure to prevent further potassium shifts out of the cell. Most of total body calcium is stored in bone, with only 1% present in the extracellular fluid. 60% of the calcium in the extracellular fluid is free or coupled with ions, while the other 40% is bound to proteins. Therefore, serum protein and pH levels can alter the ionized calcium concentration. In response to decreases in free calcium concentrations, parathyroid hormone is secreted to stimulate bone and renal tubule resorption of calcium into the bloodstream. Vitamin D increases calcium resorption within the intestines. In response to increases in serum calcium concentrations, calcitonin is released to stimulate absorption of calcium into the bone and out of the serum. Hypocalcemia is defined as a decrease in ionized, not total, calcium concentrations. As such, it can be caused by increased albumin binding from alkalosis. Therefore, hyperventilation or bicarb administration can cause hypocalcemia. If the practitioner is only looking at total serum calcium concentration, hypocalcemia may seem to be present in patients who are hypoalbuminemic. To correct for albumin levels, you take the measured calcium plus 0.8 times 4 minus albumin. Decreased parathyroid hormone secretion and disorders of vitamin D metabolism can cause acute symptomatic hypocalcemia. Often, complications of thyroid or parathyroid surgeries can lead to decreased secretion of parathyroid hormone. Renal failure may lead to decreased reabsorption of calcium in the distal nephron. During massive transfusions, the citrate preservative in blood products can bind to calcium and produce hypocalcemia. Hypocalcemia causes changes in the neuromuscular system manifesting as paresthesias, irritability, and seizures. It also causes changes in the cardiovascular system, including hypotension, myocardial depression, and ECG changes. Symptomatic hypocalcemia should be treated immediately with IV calcium. It's imperative that the practitioner also correct hypomagnesemia so that calcium administration can be effective. Respiratory or metabolic alkalosis exacerbates hypocalcemia due to its effect on calcium binding to albumin. The alkalosis should be corrected. Hypocalcemia in the presence of acidosis requires that the hypocalcemia be treated prior to correcting the acidosis. Treating the acidosis first would only worsen the hypocalcemia. Asymptomatic hypocalcemia can be treated with oral administration of calcium. Symptomatic hypocalcemia should be corrected prior to the surgical procedure, and normal calcium levels should be maintained throughout the perioperative period. The anesthetist should minimize the use of bicarb and hyperventilation to prevent calcium from binding to albumin. As seen in the picture, prolonged QT interval is an expected finding with hypocalcemia, along with decreased myocardial contractility. The anesthetist must be aware of citrates binding to calcium during massive transfusions and continually monitor ionized calcium concentration and replace as needed. Calcium levels should be monitored before and after parathyroid and thyroid surgeries because they can often cause disturbances in calcium concentrations. Hypercalcemia can be caused by an increased absorption in the intestines, as seen in Mille-alkali syndrome, vitamin D intoxication, and granulomatose diseases. It can also be caused by kidney insufficiency, leading to decreased renal excretion. Increased bone resorption of calcium can cause hypercalcemia and is often seen with hyperparathyroidism, malignancy, hyperthyroidism, and immobilization. Acute hypercalcemia is associated with neurological signs including confusion, hypotonia, depressed deep tendon reflexes, and lethargy. It also is associated with gastrointestinal symptoms such as abdominal pain and nausea and vomiting. ECG changes are also noted. Chronic hypercalcemia often presents with polyuria, hypercalciuria, and nephrolithiasis. Treatment for hypercalcemia includes diluting serum calcium and promoting excretion of excess calcium. This can be done with normal saline and the administration of furosemide. Disorders associated with osteoclastic bone resorption may need to be treated with calcitonin, bisphosphonates, or methromycin. Hydrocortisone and oral phosphates can decrease gastrointestinal absorption of calcium, and dialysis may be needed in emergency situations. Surgery may be required to treat primary or secondary hyperparathyroidism. If possible, normal calcium concentration should be restored prior to the induction of anesthesia. If postponing the procedure is not possible, the patient should be bolused with normal saline and given furosemide to enhance excretion of calcium. As depicted in the image from Stolting, hypercalcemia can cause shortening of the QT interval. Muscle relaxants should be titrated to nerve stimulation if the patient presents with muscle weakness, hypotonia, or loss of deep tendon reflexes. When dealing with disorders of magnesium, it's important to note that magnesium is primarily intracellular and found in bone. Only ionized magnesium is clinically relevant. The ionized magnesium has roughly the same concentration inside and outside the cell, producing a minimal gradient across membranes. Magnesium is absorbed and secreted by both the GI tract and the kidneys. Its excretion and absorption in the kidneys is passive and is completely determined by the movement of sodium and water through the nephron. Hypomagnesemia is primarily caused by a decreased intake of magnesium from the diet or by decreased absorption in the GI tract. Other causes include excessive renal excretion, hungry bone syndrome following parathyroidectomy, or losses following burn injury. Hypomagnesemia can cause dysrhythmias and neuromuscular symptoms such as weakness, muscle twitching, tetany, apathy, and seizures. Severe hypomagnesemia causing dysrhythmias or seizures should be treated with a bolus of 2 grams of IV magnesium and repeated until symptoms resolve. Hypomagnesemia that is not emergent should be treated with slow IV infusion. Hypomagnesemia should be identified, monitored, and treated throughout the perioperative period. It's important to realize that hypomagnesemia can be associated with hypokalemia and hypocalcemia. The two should be recognized and treated when appropriate. Ventricular dysrhythmias should be expected with low MAG levels and managed appropriately. Magnesium is passively excreted in the kidneys as it follows sodium and water. Fluid loading and diuretic use should be avoided to prevent further decreases in MAG concentrations. Hypomagnesemia can cause muscle excitability as well as weakness, and muscle relaxants should be titrated based on nerve stimulation. Hypermagnesemia is very uncommon, but can be found in renal patients who are dependent on dialysis. It can also be seen in pregnant patients who are receiving MAG infusions for preeclampsia or to prevent premature delivery. Mild hypermagnesemia, 4 to 5 milliequivalents per liter, can cause lethargy, nausea and vomiting, and facial flushing. Worsening hypermagnesemia, that's greater than 6 milliequivalents per liter, can cause a loss of deep tendon reflexes and hypotension. Extreme hypermagnesemia, greater than 10 milliequivalents per liter, the patient may experience paralysis, apnea, heart block, and/or cardiac arrest. With extreme cases of hypermagnesemia, IV calcium and hemodialysis may be required to quickly decrease magnesium concentrations. Patients with mild symptoms may only require normal saline and loop diuretics to flush out the excess MAG. Patients with significant hypermagnesemia need invasive cardiovascular monitoring to manage fluid and diuresis efforts. An A-line with frequent ABGs may be needed to manage pH and prevent acidosis from exacerbating the condition. Hypoventilation must be avoided for the same reasons. Non-depolarizing neuromuscular blocking drugs are potentiated by MAG, and the initial dose must be decreased, and maintenance of paralysis must be titrated with nerve stimulation. Hypermagnesemia is a common cause for difficulty of weaning off of a ventilator. And here is a list of my references. I want to thank all of you for your attention, and I hope the best of luck for you on the upcoming exam. Thank you.